This is your recorded lecture on dysrhythmias, cardiac dysrhythmias that we're going to be reviewing. You did learn some of this in level 2, but we're going to expand on it now in level 3. Here are your objectives. This is again for topic 5. Now, here is a picture of the electrical conduction pathways throughout the heart. If you need to review your anatomy and physiology, please do so that you're comfortable with that. We have electrical activity conduction nodes throughout the heart. Their job is to set the pace of the heartbeat. They will vary in how fast they will be firing, and that's going to give a reason for the rhythms being what they are. So your SA node is your chief pacemaker of the heart. It sits in the right atria. It's not the only node in the atria, but it is sitting there. And that is, like I said, in the right atria. That will kind of trigger your P wave. Okay, the electrical stimulus goes down through the atria and then goes through the AV node. That will be bringing your heart rate down. It will be kind of a junctional rhythm. It will be slower than the SA node. From there, the electrical pathway goes along the septum and innervates the bundle of His. Both of the ventricles will be receiving electrical impulse for contraction there. That again is going to be slower than it was for the AV node. And the last pathway is going to be your Purkinje fibers, which wrap around the bottom of each one of the ventricles and give it electrical stimulus to contract. And that is going to be very much a slower heart rate, partially because it's covering a bigger area and the muscle is so much bigger there. Now, we do have nervous system control of the heart. You have your autonomic nervous system controls, and so a part of that is going to be the parasympathetic and the sympathetic. One decreases the rate set by the SA node and slows the impulse conduction of the AV node. Sympathetic nervous system increases the rate of the SA node, increases the impulse conduction of the AV node, and then increases cardiac contractility. So be aware of how this firing and electrical stimulus makes the heart contract. Now, dysrhythmia review is usually a disorder of the impulse formation and the conduction of impulses, or both of them. Your SA node is your pacemaker of the heart, 60 to 100. Then we go down to the secondary pacemakers. AV is 40 to 60, and the Purkinje fibers are 20 to 40. So stop and think, what is a person looking like who happens to have this rate? Is it a heartbeat of 60 to 100? They're probably doing okay. 40 to 60? Some will do fine, others will not. What comorbidities do they have? And then if it's down to 20 or 40, okay, now we're really dealing with some big problems. So be aware that we can help to manipulate this rate and have better control of it. Some with chemicals, some with electrical technology. So going on to the next one, we're going to start looking at what does a 12-lead EKG show us. Okay. In critical care, we talk about the rhythm showing going across the monitor, but that only gives us one or two views of the heart. The 12-lead EKG looks at the whole heart, the front, the back, the sides, everything. You will see that these leads are numbered. So leads 1, 2, 3, AVR, AVL, and AVF is one area that looks at one area of the heart. The remaining leads look in the horizontal plane going across that of the heart. Now, we need to look at the 12-lead EKG, and cardiologists you'll have two of them look at the same 12-lead and they'll come up with different things. What do you do with the 12-lead EKG when it's obtained? You will tell the doctor what you are seeing. You will not assign a rhythm to it because we don't diagnose, right? There is a P wave in front of every QRS. the heart rate that it is showing is such and such. I am not seeing any abnormal beats on the 12-lead EKG. They'll ask you that, but nowadays all we have to do really is scan the report. So with assessment of a heart rhythm, we're going to put a name to the rhythm, but the big thing is assess your client. That's your first line. Is my client stable with this rhythm? Then determine the cause of it. Assess and treat the patient. Don't treat the monitor. You'd be amazed at how much people can handle. Okay, the big deal here is develop a systematic approach to how you're going to be looking at these rhythm strips. One type of approach, the one I prefer, is this. Is there a P wave present before every QRS? First thing, that tells you that it's originating in the sinus node. What is the rate? So take a look at how many QRSs are in a 6-second strip and multiply it times 10 to get an approximate rate. Every strip that you will be tested on in nursing school will be considered a 6-second strip. Okay, what is the PR interval? The PR interval tells you atrial, depolarization, and repolarization. There is a certain amount of time that this should be taking, so that is telling you that it's a healthy heart. You will learn how to measure that PR interval. If that PR interval is too short, then what is happening is that that heartbeat will not be as forceful. The cardiac output can be impacted. If it is too long, what is happening? Our timing is going to be off. So we talked about the ventricular rate and rhythm and how to count it. What does a QRS complex look like? Is it narrow or is it wide and bizarre? Again, we need to review what are the appropriate measurements. So the QRS is telling you that you have ventricular activity going on. The ST segment is when that ventricle, that large chamber, is repolarizing and getting ready to go again. The T wave is an indicator for us when we look at it. Is it looking normal? Is it on the isoelectric line? Is it elevated? Or is it turned upside down? Is it inverted? If it's really, really tall, where we have ST elevation, we need to be looking at our potassium and are they trying to have a myocardial infarction? The other approach is another way of counting it, but I will tell you that the approach that I just went through is probably the easiest way to remember how to calculate whether your EKG is correct or if there's a problem with it. So let's jump into sinus rhythm. This is a review of it. Sinus node fires 60 to 100 beats per minute. Look at the strip. This is a 6-second strip. You have a P for every QRS and the ST. If you look across that horizontal red line, that is called the isoelectric line. If something is above that or below it, there is something that is wrong. Now, it might be lead placement, okay? It may be a breathing irregularity, or it may be a disease state, an MI going on. So here you would measure your PR interval. What is it? Remember, every little teeny tiny box in there is 0.04. Every larger little box there is 0.20. The QRS, it's upright, it's small, narrow. That is what is normal. That's what we want to see, but how narrow is narrow? And what does our ST look like? Is our R wave to R wave to R wave to R wave regular pattern? So there's a P wave for every QRST. The PR is normal. The QRS is normal as far as the width of them. The ST is on the isoelectric line, and the R waves march out timing-wise. This is normal sinus rhythm. Okay, sinus, you have a P wave. Now we're going to go into the rate dependent. If they're bradycardic, guess what? Their heart rate is slower. If they're tachycardic, it's faster. Is that a problem? Assess your patient. Looking at this strip, you have a P wave for every QRS. The PR interval looks okay. The QRS is nice and narrow. The T wave is fine. The isoelectric line looks good. I count these. The heart rate is 40. Okay, is my patient stable? If they're an athlete, they have a big heart, they're probably just fine. If there's somebody who has taken an overdose of a medication and their blood pressure is now falling, they're not stable. So carotid sinus massage can cause this, Valsalva maneuver, hypothermia, vagal stimulation, drugs, beta blockers, calcium channel blockers, hypothyroidism, increased intracranial pressure. That can cause this rhythm to occur. So again, is your patient stable? And here's your manifestations. What do they look like? Their blood pressure is down, they're cold and clammy, they're weak, they may have chest pain because the cardiac muscle itself is not getting enough blood through the coronary arteries. They might be confused, and organ perfusion is not doing real well, and they're short of breath. So how do we treat it? Atropine, maybe. It's a drug that will increase the heart rate. Does it last long? It lasts as long as it lasts. But if it wears off and they become bradycardic again, now what are we going to do? Well, maybe what we're going to do is put on a temporary pacemaker. If it's drug-induced, too much dig, they need to be held, discontinued, whatever, maybe reduced. But it can happen. Okay, now you've looked at sinus bradycardia. We're going to go down the path towards sinus tachycardia. Okay, stress. Now, stress, as we've talked about, is not just I'm mentally stressed. It's a physiological stress. Are they sick? Okay, so the sinus node is increasing, and it might be because they have a fever. They're having pain. Their blood pressure is low, trying to maintain homeostasis. They're hypovolemic. They're anemic. They're hypoxic. Their blood glucose is really low. Are they having a heart attack? Are they in heart failure? Okay, so drugs can also impact this, like epinephrine. If they're an asthmatic or they're having an anaphylactic reaction to something that they're highly allergic to, and they take epi, their heart rate's going to go up. Levophed is another one. Did they recently get atropine? How much caffeine have they had? Theophylline is a drug that we use for respiratory, primarily as a bronchodilator, and it can drive their heart rate up. Some over-the-counter cold medicines will also have it, like pseudoephedrine. So how do we treat sinus tachycardia? What is the cause? If they're tacking along because they're in pain, let's medicate them. Vagal maneuver. Bear down, like if they were trying to have a bowel movement, that may break it. Or maybe they have to go on beta blockers. Okay, sometimes we will have what they call PACs. That's more than the P wave will come early in the cycle, premature, like a premature baby. If you look at this strip below you, you will see that you've got a P wave QRS, P wave QRS. But then that P wave comes in earlier. How do you know that? Look at your R to R interval. Okay, is this a problem? Well, if it's just a couple PACs, you probably have them every day and don't even know it. It's going to be okay. But if these are increasing in frequency, this patient may be trying to go into atrial fib, which again, you remember, can cause problems. Okay, there's your causes: stress, fatigue, caffeine, tobacco, alcohol, all those wonderful things. They may say they feel like there's a little bird fluttering in their chest. Okay, monitor them. Now, if they're really bothersome, they're symptomatic with it, we might put them on beta blockers. All right, here is paroxysmal supraventricular tachycardia, PSVT. This is atrial in origin, or not necessarily atrial, it is above the ventricle. Do you see a P wave? I'm not sure. I think so, but I'm not sure. How fast is this heart rate? Count the QRSs. Pretty fast. Are they regular? They are, and then they aren't. They are, and then they aren't. Now, the heart rate is very, very, very fast. Usually, the P wave, if there is one, is going to be hidden in the prior ST, the T wave, and you will see that that isoelectric line is not as straight and true as it should be. Okay? This occurs, it's a reentry phenomenon, reexcitation of the atria, okay? And people can tolerate it for a little while. When I saw it the first time that I took care of a patient with this, she was coming back from surgery and had her gallbladder out. And the anesthesiologist was sitting there and giving me a report, and I had her on the monitors and watching her, and she went into this real rapid rhythm. And I said, you fully reversed her, right? And he said, yeah, I did. I said, well, she's tacking along pretty well here. He said, well, she's young. Let's just watch and see a minute. Well, her blood pressure then started to go down. I said, she's not tolerating this too real well. He says, okay, she's really sleeping. Let's get some adenosine out. Well, that was a drug that we used to break this pattern if we could. So I went and got the adenosine out of the Pyxis, and you draw it up in 3 syringes, a 6 milligram, 12 milligram, 12 milligram. I also loaded up 3 20 milliliters of saline syringes and brought them to the bedside. She was symptomatic with this. Her blood pressure was coming down. We wanted to break the rhythm. So I pinched off her maintenance IV, which was on a gravity drip. The line was cleared. I pushed the 6 milligrams. I followed it with a 20 milliliter flush, and I opened up the fluid. Nothing happened. Okay, then we're going to go on to the 12. I repeated the same process. We're watching it, and she went flatline on the monitor. The anesthesiologist looked and passed out. He was a very nice man, Dr. Hansen. He knew what was going to happen. This is a chemical defibrillation is what we were doing. Now, it lasted very short amount of time. The half-life is very, very quick. She came back into a normal sinus rhythm. Everything was fine, and he had a goose egg on his head. Okay, what caused it? Catecholamine release, probably from coming up from surgery. But there can be a whole lot of other things. Disease states for sure. Ditch toxicity can cause this if they've been on digoxin. So there are your manifestations. If that heart rate goes greater than 180, we have decreased cardiac output and stroke volume. They can have angina and organ perfusion. Yet again, remember that? Okay, how do we treat it? I just told you adenosine, and I told you how we do it. Now, 10 seconds is the half-life of this drug, and most people do just fine with it. Other drugs that we might be using would be sotalol, calcium channel blockers, which is primarily going to be cardizem, and amiodarone. If vagal stimulation, drug therapy are ineffective and they're unstable, what we're going to be doing is cardioverting them. Okay, now we're on to atrial flutter. This is typically associated with the disease. You have way too many P waves, and they are a different look. They're peaked. They call this a sawtooth pattern. What happens with this is these people lose 10% of their atrial. They lose their atrial kick, which is 10% of the cardiac output. So they can be symptomatic with this. It can harm them. This also increases the risk of stroke. The QRS complex is usually normal, okay, but the ratio in flutter is usually consistent. You will have 3 P waves to 1 QRS, 4 P waves to 1 QRS, and note that they have that sawtooth pattern. Diltiazem, cardizem, is the drug of choice for this one. It'll be a push and a drip until the rhythm breaks. Or they may be sent to the EPS lab for radiofrequency ablation for long-term care. Or they may have to live with it, and they would be on medications all their life. Okay, Now we're looking at atrial fibrillation. You've still got a bazillion P waves there, and you don't know which one of those is conducting the QRS complex. And if you look at the QRS complex, it's all over the place. It does not march out. It is not regular. This is the most common dysrhythmia that we see. Prevalence of it increases with age. They will usually have an underlying heart disease. When the ventricular rate is between 60 and 100, it's atrial fib with controlled ventricular response. If the ventricular rate is greater than 100, it's atrial fib with RVR, rapid ventricular response. These people will probably be placed on a medication because we're worried about them forming clots. They will be on anticoagulants, or we may have to put in a pacer to overdrive them. You have a decrease in cardiac output and increased risk of stroke. So drugs, we talked about that. Amiodarone is one of the most common ones to try and get them to convert into sinus rhythm. Electrical cardioversion, anticoagulation, RFAs, and they can actually do a maze procedure with cryoablation, which is kind of freezing one of the electrical impulse pathways to convert. Again, look at your patient. Okay, we're going to take now a look at first-degree AV block. This is disease states again, or some drugs. Typically, this one is not real serious. Patients are usually asymptomatic. There is no treatment for it unless they are symptomatic, but monitor it. So what does it mean? It means there's a P wave for every QRS, right? But look how long that PR interval is. It's greater than 0.20 seconds. Are they symptomatic? We may have to speed them up. If they're asymptomatic, we'll just watch them, but we don't want this to deteriorate into a more severe rhythm, okay? Now, third degree heart block is very serious. Here, take a look at this. You've got a whole bunch of P waves and only 3 QRSs, and they're kind of wide and bizarre. Now, those P waves are doing their own thing, and the QRSs are doing their own thing. What I like to give you as far as an analogy to think about this is a married couple. There's Mrs. P and Mr. QRS. They're a married couple, right? They're dancing. Now, Mrs. P, the atrial contraction, the P wave, she is out there and she is just jamming to the music at her own rate. Well, Mr. QRS likes to dance more sedately, so he's dancing a waltz. They are not together. That P wave has nothing to do with that QRS that follows it. Okay? This is dangerous. Stop and think about it. The signals are all messed up. So what is this person really doing? They have a heart rate of 30 beats per minute. Looking at this one. Okay, isn't that dangerous? What are we going to do? Well, we're going to treat them with a pacemaker. We will probably be giving them some drugs to increase the heart rate while we're waiting for the pacing to kick in because it doesn't happen spontaneously. So what would be the drug? Yeah, you guessed it, atropine. Now this can be a life-threatening emergency, so get on it. Now we're going to look at ventricular dysrhythmias, such as PVCs. We're going to be looking at VTAC, polymorphic VTAC, or torsades, is that called, ventricular fibrillation. We're going to look at PEA, and we're going to look at asystole. These are all very dangerous rhythms. Okay, here is a picture with PVCs on it. If you look at the very top one, you'll see a P that's a QRS complex, and then you'll see a QRS complex that's negative. Then you'll see a P wave QRS, P wave QRS. But the next one that comes up after that is a QRS, but it's wide and it's bizarre, and it came too soon, premature, too early in the cycle. Everybody has PVCs one time or another. You may not even feel them. Maybe you'll feel an irregular pulse for a split second. The danger comes is when there are too many of them. In this second one, you have 2 PVCs together. Remember, look, the QRS complex is wide and bizarre. It's not like a normal QRS. That is 2. That's a couplet. Well, that's getting a little bit more dangerous. Go on down next to where you see the 1, 2, 3, 4 of them that are negative deflection. They're wide and bizarre. Now that's a run of V-tach. That ventricle is slamming shut, contracting very quickly. How much cardiac output is in there? How much fluid is in there? Not much. This is dangerous. On the third one, that you have an upright QRS. The second one, that R wave hit when the T wave should have been coming. That's an R on T. That can go ahead and cause you to go into V-tach. Now, the next one, you have a QRS, a PVC, a QRS, a PVC. This is in every other. This is called bigeminy. What does a PVC tell you? Irritability of the ventricle. Why is it irritable? Not enough oxygen, too much potassium, too much caffeine, too many stimulants. Nevertheless, it's happening and it is not good for the patient. Are they stable or are they unstable? Here's some different terms that they use for PVCs. Unifocal, that means it's one. Multifocal or polymorphic, the electrical conductivity is coming from different foci, so the QRSs are going to look different. Couplet is 2 in a row. Trigeminy is a pattern of 2 regular and 1 ventricular. Bigeminy is a pattern of 1 regular and 1 ventricular. A run of 3 in a row, guess what? That's V-tach. So what it causes them? Stimulants, electrolyte imbalances, hypoxia, heart disease. Okay. How many is too many per minute? 6 or more. Figure out what is going on. What is their potassium? Are they oxygenated? Anti-dysrhythmics and amiodarone is the most common, and it will be in an IV form. What are you going to do? Monitor your patient. What is their blood pressure? Are they tolerating this? Okay, V-tach, figure out why it is. A lot of times it's hypoxia. Now, your patient may be stable with V-tach. The monitor is alarming. You run in the room. You've looked at the monitor and it's V-tach. You go in the room and there's your patient, standing there, brushing their teeth. Okay, it's V-tach. They're brushing their teeth, then they turn, they say, what did you need? Well, they're stable right at the moment, okay? Are they going to stay stable with no cardiac output if this continues? No, they will not. So, check your patient first. If they are stable with this V-tach, we have some time to consider the cause and treat it chemically, which is a good thing. So, what are we going to give them? Maybe amiodarone. Okay, if that's not working, maybe we can do cardioversion. I did not say defibrillation, I said cardioversion. If we have time, give them a little sedation. Put the pads on. You will set it for cardioversion, and this is synchronized. It has to be timed with the QRS complex. If you don't make it synchronized, you're going to create chaos with that heartbeat. Now, if the monitor is screaming, you run in and look at your patient, they're down, and there's V-tach going across. Annie, are you all right? They're not responding. Okay. Start CPR, call the code, bag them, the team gets there, and then they're going to go through why is this happening to this person, consider the causes, look at the labs, and this is one where we will be defibrillating. So you go in, they're down, start CPR, call the code, plan to defibrillate, then figure out what caused this and try and fix it. All right, here is your V-tach. Wide and bizarre. Okay. This is life-threatening because they don't have any cardiac output with this. And this will deteriorate. That ventricle will wear out and will go down into V-fib. There is a little video that you can watch. Now, causes, heart disease, maybe they've had an MI, electrolyte imbalances, drugs, central nervous system disorders. Sustained VTAC causes severe decrease in their cardiac output, and you know what they will look like then. They're hypotensive, fluid sits in the lungs, no fluid going to the brain, and this will deteriorate into VFib and they will die. So this is very serious, obviously. Whoops. All right, this is another look at a type of VTAC. This is called torsades de pointe. This can be caused by an R-on-T phenomenon that we talked about a little bit earlier. Yes, these are all ventricular beats. Take a look at them. They're all different in size, shape, and this is called a turning of the points. And you can see that it's narrow, gets wider, wider, narrower, wider, wider. That's what's going on. The electrical stimulus for this one is coming from different points, different foci in the ventricle. Why is this happening? Disease, yes, absolutely. Maybe an R-on-T phenomenon. How do we take care of this person? Treatment is same as VTAC, but also include magnesium. Because this is, what does magnesium do? IV magnesium, it reduces the irritability. So this is one form of VTAC that you will go ahead and give them magnesium. Okay, now VFib. VTAC gone untreated or resistant to treatment can go into VFib, or they can be in spontaneous VFib. This one is associated with an MI, ischemia, disease states, procedures. They're unresponsive, they're pulseless, and they're apneic. What are you going to do? Call a code, start CPR. Call a code, start CPR. The code team gets there, they bring in the defibrillator, you defibrillate them. Drug therapy for them would be epi, vasopressin. You will alternate shock, med, shock, med, shock, med, and consider the causes. Now we're on to PEA, pulseless electrical activity. Well, that's a very nice sinus rhythm going across there. But when you went in there, the patient is laying there, not breathing, not responding. You can't hear a heartbeat. They're blue. So are you going to treat that lovely, nice sinus rhythm, or are you going to treat your patient? Okay. So you do have an electrical pathway going across there, but nothing is happening. Now, the prognosis for this patient is very, very, very poor. We have to figure out the underlying cause. Okay, now this wouldn't necessarily, when they're in PEA, it might look like VTAC, it might look like sinus rhythm, it might look like atrial fib. But the thing is, all it is a pretty picture. Nothing is happening within that cardiac muscle. These people are trying to die. Here are your H's and your T's. This is your mnemonic. Is it because of hypovolemia, hypoxia, acidosis, hyper or hypokalemia, and hypothermia? Or is it because they have toxins in their blood? Cardiac tamponade. They came back from surgery and the cabbage and the blood vessel came off of the heart, and now blood is going everywhere. Did they toss a thrombus? Okay. Do they have a tension pneumo, or have they had trauma? What is the treatment for PEA? CPR will get them intubated. Try IV epi. Treatment is directed towards correction of the underlying cause. So how do you know that they're hypovolemic? Well, check their CVP, their butyl-creatinine. How do you know they're hypoxic? Oximeter. How do you know they're acidotic? Get a blood gas. How do you know they're hyper or hypokalemic? Get a lab test. Hypothermic, take their temperature. Toxins. Draw a lab, send it off. What medications have they been on? Tamponade. Are all the chambers of the heart the same pressure? That's going to be using your Swan-Ganz catheter. A thrombus? Won't know until you go in and take a picture of it or inject dye, contrast, and find it. Tension pneumo. What are their lung sounds? Do they have tracheal deviation, tracheal shift? And trauma. Were they in a recent trauma? Now we're on to asystole. Nice sinus rhythm going across and then flat line. You run in the room. Are they standing there and ripping their leads off because they want to take a shower? Or are they laying in the bed, totally gone? They're not responding to you. There's no blood pressure. There's no pulse. They're not breathing. This is total absence of ventricular electrical activity. There's no ventricular contraction. You have to assess this in more than one lead, okay, and you have that capability when you have them on a monitor. This is usually the result of advanced cardiac disease, okay, conduction disturbances, or end-stage heart failure. Treat with immediate CPR and ACLS protocols, epi and vasopressin, intubation, but in asystole, it's a poor prognosis. All right, here is your sudden cardiac death. This is death from a cardiac cause. This is usually as a result of ventricular dysrhythmias like VTAC or VFib. Life-threatening dysrhythmias caused by anti-dysrhythmia drugs. Okay. Do we give them too much? Did we suppress them too much? Digoxin and class 1A, 1C, and 3 anti-dysrhythmic drugs can cause this. People are more susceptible the first few days of drug therapy, so we monitor them. Okay, we have to know what their tolerance for the drugs that we're giving them actually is. How much do they actually need? What is defibrillation? Well, they've died from a cardiac cause, and we're going to apply electrical stimulus. We're going to defibrillate them. So would you know how to do that? That's what we're going to be looking at. You're doing CPR. We have no blood pressure. They're not breathing. We're bagging them. So we're going to go ahead and put the pads on them and get the defibrillator in the room. Now here's a picture of how we do that. You place the pads on the upper right chest and just below the nipple line. It's a good idea to plug the defibrillator in and to turn it on. Now, these have two different modes. They'll have cardioversion and they will have defibrillation. If your patient is dying, we're going to defibrillate. Okay, you continue CPR, the paddles are on. The doctor says set it to 260 joules. You turn it and it goes ding, it's on. And then what you do is you say, everybody clear, get away, get away, get away, look around and shock them. Then you will start CPR and they will look and see if we have a rhythm back. Now this is your defibrillator. They have many buttons. When you're working in a hospital, you will be checking the code card. Do the code card, so do the quality control on that so you know what's there. You will go through classes to learn how to use a defibrillator. This is different from the AED. The AED guides you right through the process, but a defibrillator, you have to set it the way you want it to be. Start CPR while getting ready to go. Turn it on. Select the energy. Make sure the sync button is turned off. We use the sync button when we do cardioversion. Put the pads on, charge it. Yell all clear. Make sure you stand back. Put your hands up in the air. You will not be bagging them during this time. Deliver the charge. Now we're on to synchronized cardioversion. Now this is for your stable VTAC people. They have a pulse, or some of the supraventricular tachydysrhythmias. It's the same process, but what we're going to do is synchronize this. We will turn it to cardioversion. The amplitude that we fire it at will be much lower, and we put it on synchronized, and then it will tie it to the R wave so that we don't deliver the shock when the ST is appearing, because that is repolarization, and then we won't get anywhere if we do it that way. Okay, so make sure your sync button is on for synchronized cardioversion. Now here's a couple little videos that you can watch. If you have the time, sedate your client. Your energy level for firing this will be lower, 70 to 75 if it's biphasic, 100 if it's monophasic. But the big thing is if you were doing defibrillation, you would be looking at 260 to start. Big difference. Now, You started this process, the patient had a pulse. If it deteriorates so they don't have a pulse, then you're going to turn the sync button off and you're going to go into defibrillation mode. Okay, we're on to implantable cardiac defibrillators, ICDs. Patients who have survived a sudden cardiac death, if they have spontaneous sustained VTAC that they can't ablate, they can't get under control with medications, are at a high risk for future life-threatening dysrhythmias, we will place an internal cardiac defibrillator. It also has a pacemaker mode usually attached. These can be in the chest, they can be in the abdomen. They're placed in cath lab or in surgery. It's a lead system. It goes the subclavian vein. We'll thread a lead down to the endocardium, and then that will be connected to your generator, which is implanted subcutaneously, either in the chest or the abdomen. This defibrillator senses rhythms, the heart rate, and if it identifies one that is aberrant, that should not be, it will deliver 25 joules or less to reset the rhythm of the heart. This thing can also do overdrive pacing for tachycardias. It'll deliver the shock to settle down the P waves and slow the heart rate. It can be a backup pacer for bradycardias. If it's not sensing, it's just like a pacemaker. The pre-procedure and post-procedure care are the same as if we were doing a pacemaker. Now they're scared. Can I go near a microwave? Yeah, you can. But can they have an MRI? Now you're going to find some people with ICDs that were put in a long, long time ago, and they may not be MR compatible. Make sure you ask them. Hook them up with a support group, because this is a scary thing. Without that machine working, I might die. Think about it. Patient and caregiver teaching, they have to know when their follow-up appointments are. Incision care, watch for signs or symptoms of infection. If they place it in the chest, we have the same arm restrictions. Same thing with sexual activity, driving, avoid direct blows. Yeah, okay. Car crashes, if they have a seatbelt on and the airbag explodes, think that. And avoid large magnets. I told you that before with the MRI. Pretty important. Okay, some more teachings. I guess I like that you got more information. Well, I hope you learned something from this recorded lecture, and we'll be seeing you in class.